insomnia, what to do when you can't sleep. And so I thought we'd start just with a really brief overview of what insomnia is, because it's a tough diagnosis for clinicians to make, which makes it even harder for patients and their families to deal with a condition that is actually what we would call a diagnosis of exclusion, something that we have to almost rule out every other possibility before we can come to the final diagnosis of insomnia, even though it's probably what's been going on the entire time. Medicine is all about Latin words because it makes us sound smart, but in reality, they just mean the very simple things. So insomnia is essentially no sleep in Latin, or sleeplessness. In broader terms, though, there's two main types of insomnia. There's the sleep onset insomnia, which is where you have that difficulty getting to sleep. Typically, it's defined as taking more than 30 minutes to fall asleep on a regular basis. But it's that initial period where you get into bed, you turn the lights off, you shut your eyes, and you're lying there hoping that you'll drift off to sleep quickly. But unfortunately, in a number of people, that can take a lot longer than the 10 to 15 minutes that should be the normal range to fall asleep in. And then there's a separate type of sleep insomnia, which is sleep maintenance insomnia. And that's where it's difficult to stay asleep. It's where you get to sleep. Once you're asleep, within an hour, 2 hours, 3 hours, you'll wake up. And the issue with waking up is only part of that sleep maintenance insomnia. It's also then unable to get back to sleep. And so there's wake periods of more than 30 minutes. There is a rarer form, which is called early waking insomnia. And it's people who consistently wake up more than 30 minutes before they want to wake up. And that is a type of insomnia, and typically will come in with the rest of the insomnias. And most patients will actually present with sleep onset and sleep maintenance insomnia to certain degrees, and trying to elicit which is which will help us then determine the best management plans. The type of insomnia that almost all of us will suffer at some point in our life is acute insomnia. That's where the symptoms are there for only a short period of time, up to 3 months. And it's usually associated with a very clear life stressor. And whether that's a bereavement in the family, those going through a divorce or a tough relationship, workplace stress, or any other reason, that clear stressor sort of defines acute insomnia. The symptoms tend to improve when you are able to manage that stressing event. Separately, though, and why we are all here today, is the chronic insomnia. Those are the people who suffer from these symptoms for more than 3 months, often for many, many years before they come to our attention. And that population is about 10% of all adults in this country, which is a very large number. Beyond just what the different types of insomnia is, it's important to know that these symptoms have to be there for at least 3 nights a week for greater than 3 months, that you need to be giving yourself an opportunity to sleep for an adequate duration. So it's not for those who are staying up late playing games all night and then sleeping for 2 to 3 hours, but the diagnosis of insomnia is based on the fact that you are trying to sleep for what you believe is an adequate amount of time, that it then impairs what you do during the day. And that's the key for a diagnosis. A normal amount of sleep is essentially how much sleep you and your body needs to function normally in your daytime activities. And the moment that starts to become impaired, that's when we start to worry about conditions such as insomnia. And typically, but not always, there's an absence of any other sleep disorder, which is why we call it a diagnosis of exclusion. We have to look for those other sleep disorders, such as obstructive sleep apnea or restless leg syndrome, treat those first if we find them, and then determine if there is still ongoing issues with sleep quality, both in sleep onset and sleep maintenance. Some of the conditions that are often mislabeled as insomnia are those who have what are known as a short sleep syndrome. And that is essentially what is a normal sleep for that person. Like I said, it's only a sleep disorder if you are having impairments in your daytime function, or there is a risk to your health in other ways, such as heart disease as a result of poor sleep. If you can function on 3 to 4 hours of sleep every night without any problems during the day, and there's no other sleep disorder that's present, then you would be what would be called a short sleeper, and that is normal. And that also doesn't include sleep restriction, which is people who choose for a variety of reasons to have a shortened sleep time and therefore have impaired daytime function because of that lack of time allocated to sleep each night. If they slept a normal amount for them and for them to wake up feeling refreshed, typically they would no longer have symptoms. What are those symptoms? So overnight, it's quite clear. It's people struggling to get to sleep. It's people waking up during the night and then difficulty returning to sleep. But the ones that we commonly will discuss in our clinic appointments with people who present to us with insomnia are when there's increase in anxiety or stress about the concept of sleep. They've had these symptoms for such a long time that they start to become nervous about going to sleep, worried about how long it will take them to sleep. And then once they are in bed, they start to clock watch. And a lot of people can resonate that when we even mention the word clock watch, having never heard that phrase before, because 20, 30, 40 minutes into a night trying to fall asleep, suddenly you start to worry about how long is it going to take and are you going to get enough sleep to wake up feeling refreshed the next morning. And once you start looking at that clock, suddenly time begins to slow. But that also adds to that stress and it's a bit of a revolving cycle. During the day is also a really important time for us to work out is there ongoing impairment, and that would be part of that diagnosis of insomnia. So do you have issues with fatigue and irritability? Is there anxiety and stress that is driving some of those issues sleeping overnight? We know that poor sleep will impair your function and that can lead to poor concentration, memory, or attention. You can experience a low mood. And you may get symptoms such as headaches or a low libido. Who's more likely to get insomnia? Well, there's a few different factors. We call it the 3P model: the predisposing factors, the perpetuating factors, and the precipitating factors. The people who are predisposed to insomnia are those who already have a history of anxiety, stress, or worry, and this can feed into that issue. People who have an inappropriate expectation about sleep quality and sleep maintenance, but also of how much sleep they truly require. There is a genetic component to insomnia. And as you get older, the risk of insomnia does increase. Once those risk factors are present, the triggers for developing actual insomnia and chronic insomnia that's diagnosed include poor sleep hygiene, and we'll spend some time later on in this presentation discussing how we can address sleep hygiene or sleep habits. As we talked about, life stresses certainly play a big role, but so can conditions such as chronic pain, menopause. We know that the circadian rhythm, which is your body's natural body clock, has a major role in your entire sleep cycle, but conditions that can affect that or work or environments that can affect that include those who have to do shift work and constantly changing between shifts, particularly between night and day shifts. Those who travel between time zones on a regular basis also will be affected by that. And that will, knowing those precipitating factors will certainly affect how they are best managed. But also medications, illicit substances, and in particular alcohol and caffeine, which are commonplace in our society, but certainly play a role in the quality of sleep. We also know that health conditions, whether they be mental health disorders, conditions affecting the heart, lungs, or other organs, or sleep disorders, all can lead to the development of insomnia. And once insomnia does develop, like we talked about, unfortunately, it can become a bit of a cycle. You can become anxious about your sleep. You start to have compensatory behavior, such as increasing your caffeine intake to get through the day, which then affects your sleep at night, and it's an endless cycle. You start to lose what is true perception of how much sleep you have had and how good the quality of that sleep has been. And you start to worry about what sleep should be because you look back at a time in your life when you felt that your sleep was better and have suddenly start to have a bit of a dysfunctional belief around that. What happens when you do develop insomnia? Well, it can impact your entire body. Like we talked about, there is an impairment in your daytime function, and that can lead to poor attention, poor concentration, decreased work performance, and also impaired decision making. But also, poor sleep quality has a major role in weight maintenance and can lead to weight gain. You're also at higher risk of heart disease, of diabetes, of lower immune function, And importantly, for a lot of our clients that we see, there is an increased risk of motor vehicle accidents, and managing that risk is important. So when should you see a doctor if you're worried about your sleep, and in particular if you're worried about insomnia? And I think the general rule is to see your GP as soon as you start to be concerned about your sleep patterns or they're starting to cause issues for you during the day. If there is a clear life stressor and for a few days in a week you have some poor sleep, but you deal with that stress and suddenly your sleep's improved, we wouldn't need to see you as doctors. But the moment that you start to be concerned that this is becoming a habit or that there is significant impairment in your daytime function, we should be seeing you. And in particular, we think that we should be seeing any patient that snores, is restless in bed, has poor mood or anxiety that may be related to their sleep quality, or they're consistently waking unrefreshed. And like I said, insomnia is a diagnosis of exclusion. So some of the things that we look at before we confirm that the diagnosis truly is insomnia is it people who are not giving themselves an adequate amount of sleep or time to sleep in bed? Do they have chronic sleep insufficiency? Do they have conditions that affect their breathing overnight, such as obstructive sleep apnea, which is an incredibly common condition? About 1 in 4 Australian males will suffer this. Restless leg syndrome is another condition that can impair the quality and maintenance of sleep and lead to arousals throughout the night. We briefly touched on earlier conditions called the circadian rhythm disorders, where your body's natural body clock has been put out of sync for a number of different reasons, and they can be due to shift work. You may have a delayed sleep-awake phase where you sleep later in the evenings or into the early morning and wake up later as a result. And the opposite is also true, where it may be advanced and you sleep early and therefore have to wake early. And other medical issues can also contribute to either the development of insomnia or symptoms that mimic insomnia. And the question, and one that we answer frequently when we are referred these patients, is who of our patients who present with features consistent with insomnia truly need a sleep study? And it's where the history from our patients and trying to elicit the symptoms that have led to this point are really important. We know that if we miss the diagnosis of another sleep disorder, none of our interventions to treat the insomnia are really going to be effective until we fix the underlying sleep disorder. And so we do have a low threshold for organizing a sleep study. This is one of those studies where you wear a little harness connected to a box, which is a recording device. And there is a number of different wires, as you can see, attached. Some are recording brain waves, others recording the flow of air across your nasal passages. And an oxygen trace is another feature that we monitor. And we're looking for conditions such as sleep apnea or restless leg syndrome. Typically, if you have presented to us after having the standard treatment plan for chronic insomnia and that hasn't worked, we would then be really keen on performing a sleep study to see, have we missed an underlying sleep disorder? And it is not uncommon to have features of insomnia only despite having conditions such as sleep apnea. We call those silent sleep disorders. So here's the most important part. How do we manage insomnia? How do we improve your sleep quality? We have a multi-stage approach to managing insomnia, but the most important parts are here at the front. Sleep hygiene, improving that and optimizing the quality of your sleep as much as possible. And if that has failed to achieve the desired result, then moving on to the behavioral therapy approach. Sleep hygiene is important for everyone, not just those with insomnia. And certainly all of us can learn to improve our sleep hygiene and our sleep habits to ensure that we get the best quality night's sleep overnight. I'm certainly as guilty as everyone of breaking these rules on a regular basis. So some of the healthy sleep habits to prevent insomnia in those who do have a normal sleep for them at the moment is making sure that you have a consistent sleep schedule, trying your best to maintain the same wake time in particular, but certainly the wake and sleep times are both important. maintaining a healthy lifestyle, both in terms of diet and regular exercise, avoiding excessive amounts of alcohol, caffeine, and tobacco. And our general rule is for caffeine, trying to minimize intake, certainly after lunch, but at the latest 2 p.m. Avoiding taking naps, and if you do, keep them to 20 to 30 minutes in duration. Trying not to eat too late and going to bed on a full stomach. And finally, and one of the more important ones in this day and age, is limiting that screen time before bed. Probably in the last decade, if not the last 15 years, the dependence on screens has increased exponentially. We're all now staring at a little blue rectangle on a regular basis, whether that's in bed as soon as we wake up throughout the day. And what we're doing each time is feeding our body with blue light. Historically, going back centuries, the major source of lighting for all humans was natural, which was the sun. And when the sun went down, the evenings were spent in relative darkness. And it's really only in the last century, if not even shorter, that blue light or unnatural light in the evenings has started to play a major role in society, and it has impacted sleep significantly. We know that the natural circadian rhythm, which is what drives our body clock, which drives the desire to sleep and the desire to wake, relies on light to function. And blue light, we know during the daytime, keeps you alert, awake, it boosts your attention, your mood, and reaction time. However, at night, those exact same things will occur as well, and they have a counterproductive effect on our desire to sleep. And studies have shown that blue light in particular will suppress melatonin secretion and cause shifts in that circadian rhythm and affect that natural body clock. And so one of the first things that I talk about with my patients whenever they discuss their sleep and their inability to get to sleep or stay asleep is how much blue light they're exposed to, particularly in those last 1 to 3 hours before bed. And then we discuss strategies to try and minimize that as much as possible. And some of the things that you can do, and we should all be trying to do this even before sleep disorders develop, is trying to use a dimmer light, or what we call a redder light, and it's certainly readily available light bulbs or lamps that can be controlled both for colors, but also the natural color is more of a redder or orange light than a blue-white light. We avoid those bright screens in the 1 to 3 hours before bed, and that includes TVs, iPads, computers, and phones. We can think if avoiding them altogether is impossible, of putting blue blocking glasses on, which are readily available from many optometry retailers and can be fitted on standard reading glasses as well. Or lots of phones and computers these days, including most iPhones, will have what's called a night shift mode, which will naturally shift the color on the screen to a more yellow or redder tone. And that can be set automatically or manually to start at a certain hour of the day to try and minimize the blue light. Now, there's conflicting evidence about whether that is as effective as the manufacturers would make you believe, but certainly is not causing any harm and may be of benefit. And equally to avoiding the blue light during the nighttime, exposing yourself to as much bright natural light during the day, preferably sunlight, is equally as important to maintaining that natural circadian rhythm that will impact and improve your sleep quality overnight. The Sleep Health Foundation in Australia about 4 years ago put up an excellent document about the 10 tips for a good night's sleep. And I share these with a lot of my patients, and a lot of them are, with these tips alone, is enough to improve their sleep quality to a point where they no longer have impaired daytime function. They're things that we can all do, and they're not difficult. A lot of that is what we've already discussed, but having a regular sleep pattern, spending the right amount of time in bed, and that means trying to maintain bed for bedtime activities only, which is sleep and sex. Trying not to spend the entire evening in bed watching Netflix, reading a book for prolonged periods of time, having conversations on the phone. Do those in other areas, and then get to bed and get into bed when it's time for those bedtime activities. Trying to develop practices where you're winding down and relaxing as you get closer and closer to bedtime. the minimizing those stimulating activities, whether those are video games, like we said, use of your phone, watching thrilling dramas on TV, and trying to practice activities such as listening to calming music, meditation, reading a calming book before drifting off to bed. When you're in bed, make sure it's comfortable with both the temperature, the noise levels, and like we discussed, avoiding alcohol, caffeine, cigarettes, and daytime naps if possible. Once you are in bed and trying to sleep, the key is not to stay in bed watching the clock if you can't fall asleep within your desired time frame, but actually to get up and do something else before trying to get back to sleep when you start to feel that urge to sleep come on again. We like to avoid sleeping pills except in exceptional circumstances, and we'll talk about that a bit later. And finally, if none of these tips have helped, think about seeking professional help. Some of the other sleep hygiene actions that I tend to recommend to my patients are often their concerns and their difficulty getting to sleep, in particular with sleep onset, is around worrying around their daytime stresses, whether that be in the workplace or in their home life. And trying to resolve these as much as possible before bed will help you drift off to bed in a more comfortable mindset. Sometimes we set aside a period of time called worry time, where people will either sit and ponder those concerns or worries and spend some time trying to deal with them. Others will actually sit down and journal those concerns out on paper. And once they've had their worry time, they often are in a better mindset to then try and sleep. We also recommend trying to avoid going to bed until you are drowsy or you're ready to sleep, and trying not to force sleep. Like we said, if you're not asleep within 30 minutes, you can get up, go to a dark, quiet room, and stay there until you're sleepy again. We would actually recommend for a lot of people to have that room already set up before you go to bed if you know that sleep onset is an issue for you, so that the moment you start to realize that you're not going to drift off to sleep within the desired time frame, you're ready to go with your dressing gown and your slippers by the bedside. You pick them up, you get yourself into that new room, and you will have something there to keep you occupied, but not overly stimulated. So that might be a book with a dim light. It might be calming music, but staying in that different environment away from bed until you start to feel sleepy again, and then going back to try again. Like we said, avoiding those large meals before bed, keeping a healthy lifestyle, including exercise for at least 20 minutes a day, but not within the last 1 to 2 hours before bedtime. I'm very guilty of having my pet sleep in the bed with me, but certainly if you're having difficulties with sleeping, then those external factors can certainly play a major role. And like we said, allowing sufficient time in bed to gain an adequate amount of sleep. So knowing what is a good amount of sleep for yourself to wake up feeling refreshed the next day and be able to function throughout the entirety of the next day is helpful, and then determining how much time you need to spend in bed each night. If improving your sleep hygiene alone isn't enough to improve the quality of your sleep, both in sleep onset and sleep maintenance, if you've been diagnosed with insomnia by a health professional such as your GP, the first line of treatment is that of behavioral therapy. It is the only line of treatment that has proven evidence to work and work in the long term, and is certainly what I practice with my patients, of really trying to improve the behaviors that surround sleep. In the short term, we talk about brief behavioral therapy, which often can help, especially if the insomnia pattern hasn't been established for a number of years. And so brief behavioral therapy we practice frequently in our clinics. And that is two main factors. One is restricting the amount of time in bed to around about the average sleep time, but plus about 30 minutes, and continuing this for about 2 weeks without any adjustments. But more importantly is that stimulus control. So that's where the sleep hygiene really plays a role. It's about getting up at the exact same time each day, regardless of whether it's a weekend or a weekday, regardless of how much sleep you've had. If you struggle to sleep for 4 hours and only get 3 hours of sleep, but 7 o'clock is your wake up time, then you're up and out of bed at 7 o'clock and you're up and getting that natural light as much as possible. It's also important to only go to bed when sleepy, to stay in bed only when asleep, and trying to get out of bed if you're not falling asleep in those first 15 to 20 minutes, And like we said, having those plans in place of what you're going to do if you can't fall asleep, and also trying to avoid napping during the day. And for a lot of people, this is all that's ever required to improve their insomnia. And while it can take a long time to establish these patterns, the effort is worth it because in the long term, their sleep quality returns to where they would want it to be. What happens when the brief behavioral therapy doesn't work? That's when cognitive behavioral therapy for insomnia is very, very effective. Now, this is CBTI, and some of you may know of cognitive behavioral therapy or CBT, which is used for a lot of different conditions, including mental health disorders. Cognitive behavioral therapy for insomnia, or CBTI, is a very, very different program, and it's delivered by specialist sleep psychologists. And it is the first-line treatment for chronic insomnia that's recommended by most sleep societies and guideline panels. We have strong evidence to say that it's superior to medication alone, both in the short but also the long term. It's a multi-component approach. It deals with both the thoughts around sleep and the behaviors that interfere with optimal sleep. It's delivered over 4 to 8 sessions, and it's distinct, like we said, from other forms of CBT. The behavioral components really focus around sleep restriction. And the way I describe it to people is we need to break your sleep in order to rebuild your sleep. When we're seeing patients with insomnia, and typically chronic insomnia that's been present for a number of years and failed a number of different treatment strategies, those long-standing habits and those long-standing behaviors around sleep have been so ingrained in the body that sudden changes will make no impact. So we really need to completely break down the sleep and then rebuild the sleep as per how you want it to be. Sleep restriction is essentially the only way to do that. And this is why it's important to do this with trained professionals, including a sleep psychologist, because it can be quite restrictive. We develop a plan and we don't enact the plan until we know it's a safe time to do so, both in terms of quality of your sleep, but also your family, and how a lower sleep amount each night for a short period of time will impact people during the day. The sleep restriction essentially means reducing the amount of time in bed to a certain amount of estimated hours, but maintaining that wake time, which is the most important. So as a pure example, you may say that you need to sleep for 7 hours each night to be able to wake refreshed and perform your daytime activities without a problem, and you want to wake up at 6 a.m. At the moment, you're unable to sleep for more than 2 hours at a time before waking up. And so what we would say in the first week, once we've developed a plan, is that you're going to wake up at 6 a.m. no matter how much you sleep, but you're not allowed to sleep until 3 o'clock in the morning. That means you only have 3 hours in bed to sleep. And if you're asleep for those 3 hours, excellent. But if you're only asleep for one of those 3 hours, you're still waking up at 6 a.m. no matter what. The first night you will struggle, but you'll get there. The second night you'll really struggle. You may have a little doze as you're trying to stay up until that 3 a.m. But by the third night, you've developed what we call a sleep debt. And that sleep debt is really important to establish the patterns of behavior that we want to develop for your new sleep cycle. And so you'll probably crash, you'll sleep through the night, you still need to wake up at 6 a.m. And then you need to go through the whole process again to really establish those 3 hours before we then can think about 4 hours, 5 hours, or 6 hours. And it's not just sleep restriction, although that plays the basis of it. We also do the stimulus control activities and the sleep hygiene activities we've previously discussed. We maintain that stable bedtime and wake time throughout the week, no matter whether it's the weekend or the work day. And we also address the cognitive components around sleep. So that's both the anxiety and catastrophic thoughts that you associate with sleeplessness, but also your expectation about how much sleep you truly need. We correct your misperceptions of how sleepless you truly are. And we try and provide relaxation techniques. And this is why performing this program with a sleep psychologist is incredibly important, because they will tailor this to strategies and techniques that work best for you. They will give you a number of different tools and try and work out which works and which don't, and then focus on the ones that have had the best benefit. Bright light therapy is a technique that some people recommend for insomnia. It certainly has a role in people who have those circadian rhythm disorders, such as a delayed sleep phase, but can also help when you're waking up feeling unrefreshed, especially in the winter months where natural light is not as readily available. Timing your bright light in the morning for those with sleep onset insomnia can help to advance the circadian rhythm and allow you to fall asleep more easily the following night. And likewise, for those who are waking up too early and unable to get back to sleep, having a little bit of bright light in the evening can delay your sleep phase just enough that you can get through to your desired wake time. When do we consider medications? I personally have a strong opinion on sleeping pills, and we'll discuss those reasons shortly. But typically, we wouldn't even consider medication for sleep unless there was a failure to respond to other treatments, and those being sleep hygiene improvements and CBTI. Once we've ruled out any other sleep or medical disorder that could be contributing to insomnia, or at the very least optimize those. And we've balanced the risks of treating insomnia with any medication side effects. We know that sleeping pills in general, and we'll talk about the different types, have many different side effects, the most common of which is drowsiness the following day, which can then lead to reduced cognition and reaction time, as well as increased risk of accidents. But we also know that there can be dependence as well as tolerance, where the effect wears off. You increase your risk of organ disorders such as liver and heart disease, but you also increase your risk of death due to either long-term use or, unfortunately, in some people, abuse of those medications. Separately, though, we know that not being able to sleep or poor sleep has its own health risks, and they can include decreasing the quality of life, but also increasing the risk of medical and mental health disorders, increasing the risk of substance use disorders, and in particular alcohol, which can be used as a sedative, as well as decreasing your performance in your daily tasks if you're unable to sleep. And so we really need to balance the risks of the medication versus the benefits of getting a good night's sleep whenever we make the decision to prescribe sleeping pills. Some of the more common medications that we see our patients use are over-the-counter medications, rest of it being a very common one, which is an antihistamine. These medications were truly designed for short-term use only, for people with acute insomnia, typically with a stress that has a clearly defined endpoint, and using them for less than 4 weeks at a time in conjunction with any of the other, what we call non-pharmacologic therapies or the other behavioral therapies. The problem with rest of it is it does interact with a number of different medications. And so it's very important to discuss this with any doctor or pharmacist who is helping you prescribe these medications. There are also a number of sleep supplements on the market, typically available in a combined format. Blackmores and Swiss are two of the more common ones available in Australia, and they will have a number of these different herbal and traditional medicines in combination. For some people, they work very well, while for others, they have minimal to no impact. What's important is ensuring that none of these medicines interact with any other medicines that you are on. Melatonin is a very commonly used treatment, both over the counter as well as prescribed by healthcare professionals. We know that there is not a lot of evidence for its use in insomnia, but generally it is safe. It works best when it's taken about 1 hour before bedtime and can help to augment the natural circadian rhythm, which is driven by the release of melatonin naturally in the body, although to much lower doses. One large systematic review, which in medicine is one of the strongest forms of evidence, showed that there was a statistically significant improvement in both sleep latency, or the time taken to fall asleep, as well as the total sleep time. But it was such a small improvement that is that actually meaningful to the patient. And melatonin does have side effects. The more common one is vivid dreams and nightmares, but it can also cause headaches and dizziness. Sometimes people do suffer from daytime drowsiness, and it can affect your mood and cause some irritability as well. Prescription medications are also used, and unfortunately, in some places, used a bit too commonly and for too long a duration of time. The more common ones are benzodiazepines, of which Temase or temazepam is probably the most common. Z drugs such as zolpidem, as well as a newer medication called suvorexant or Belsomra. We like to use these for a maximum of 4 weeks at a time, using them intermittently rather than nightly, for the lowest dose possible and minimizing that dose as much as possible. And most importantly is before even considering starting these medications, we should have a plan of when and how we're going to withdraw them. And finally, medication-wise, there is a number of medications that can be used off-label. So they're designed for other purposes, but they may have an impact on sleep. The two most common ones are two antidepressant medications, mirtazapine, which is shown to cause significant improvements in sleep time, the time in bed that you are asleep, as well as the quality of that sleep in those who have major depression as well as insomnia. When used for insomnia alone, there are improvements as well, although these are much smaller and at much lower doses. And once the doses increase beyond what we call 7.5 milligrams, those benefits diminish. Amitriptyline is a very old antidepressant, and in a lot of people has been trialed. There is minimal evidence that it helps, but particularly in people with depression as well as insomnia, there has been in studies some improvement in both the time it takes to stay asleep, to get to sleep, but also to stay asleep. So just finishing up, when should you see a sleep physician or a sleep specialist? The three most common reasons would be when the diagnosis is unclear. So the features may be suggestive of other sleep disorders, for example. If the insomnia is what we call complex insomnia, and that's insomnia that's associated with other medical or sleep conditions, such as insomnia and obstructive sleep apnea. Or when following the standard insomnia treatment plan that we've just outlined, there's a failure to improve. So in summary, insomnia, like we discussed, is the inability to fall asleep or maintain sleep, as well as an impairment in daytime function, and typically in the absence of other medical or sleep-related disorders that could cause these symptoms. We know that there are significant health impacts from poor sleep quality and duration, and that if you're worried about your sleep, you should see your doctor, and further investigations may be warranted. The best treatment for insomnia is prevention, and that starts with optimizing your sleep hygiene. But if that alone hasn't been effective, then cognitive behavioral therapy is the best treatment long-term. Medications may be required, ideally for only short periods of time and using intermittently. And seeing a sleep specialist can help to determine the diagnosis, make sure that there's no other sleep condition that has been left untreated, but also devise strategies when there is a failure to improve. Any questions? I think we've got a few on the chat there.
Fantastic, Harsh. Thank you very much for that. That was truly terrific presentation. Very, very systematic and nice way to go through what insomnia actually is, and then go through a really nice way in which it can be managed and people